Hey
And so a
guys, welcome
partially
back to my
compensated would be
channel.
like, say,
So, night for me. Yay. So, tonight I wanted to come on and talk about how to interpret arterial blood gases. It's very important, as a respiratory therapist to know how to interpret your ABGs. If you're a student and you're trying to learn, it's it's not too bad. I actually love interpreting arterial blood gases, and you know you have to know when you're interpreting, you have to know what to do. You have to know what you're looking at first of all, and you have to know what to do with the numbers that you have. So you can actually know what it is, but may not know what to do with it. So you have, with your arterial blood gas, you have your pH, you have your CO2, your PCO2, and you have your bicarb, and of course your PaO2. So start with normal ranges. Normal ranges for a PCO2 is 35 to 45. For your bicarb is 22 to 26. For, of course, your PaO2 is 80 to 100, but it also depends on if this patient is on oxygen or not. It always should be like 5 times whatever amount the person is on oxygen. So say they're on 40%. So honestly, if they're on 40%, 40 times what 5 is what, 200. So if in normal lungs, they should be about 200. So it just depends on the percentage of oxygen that the person is on. Um, let's see. I said the pH, the PCO2. Oh, the PCO2 is 35 to 45. So now, when interpreting your blood gases, you have what you call um, your respiratory acidosis, your respiratory alkalosis, your metabolic acidosis, and your metabolic alkalosis. Also, you have the term we call fully compensated or partially compensated. So, let's start off with our pH and our bicarb. Our pH and our bicarb they work directly proportional. So they're like husband and wife. They work together. They're partners. So if one's going to be up, the other one's going to be up. The other one is down, the other one's going to be down. So the cool thing about a body is when it notices that, okay, something's not right, the lungs will compensate for your kidneys, and vice versa, the kidneys will compensate for your lungs, all in order to try to get the pH back up to where it needs to be. So say you have a pH of like 7.1, which is a bad blood gas, is low. So already with a pH of 7.1, you know this is acidic, it's acidotic. So the acidotic would be on the lower side, the alkalotic would be on the higher side. Your alkalotic would be something like 7.48, 7.5, 7.6. So say you got a pH of 7.1 and your CO2 is like 60. So already there, it's a respiratory acidosis because your CO2 is elevated. So remember, normal CO2 is 35 to 45. So anything higher is going to be your respiratory acidosis, especially with your pH being low. So, so with this case, so say 7.1 is your pH, PCO2 is 60, and say your bicarb, remember bicarb and your pH were directly proportional. So that bicarb is going to try to compensate because it knows something's not right. My pH is low and my CO2 is high. So I need my pH to be back with me. I need my pH to be back normal. So it's going to go down, well, it's going to go up, I'm sorry. It's going to go up because it wants its mate back up. So remember, like husband and wife, if you notice like your husband's down and you're the wife, then it's like, okay, something's not right. Let me do something to motivate him and push him back up. So I'm going to rise, so he'll rise. So it's like that. If you want to, and the thing about blood gases, you can find some type of cool analogy to try to understand it. And so always try to find some type of analogy to get it. So, okay. pH 7.1, CO2 is 60, my bicarb is going up, is 40. So at that point, okay, my bicarb is trying to go up because it's trying to bring my pH back up. So that would be called like a partially compensated. It's partially compensated because it's trying to go up to bring that pH up, but it's not there yet. So a fully compensated would look like this. It would be like a pH of 7.36. CO2 will still probably be like 60, but your bicarb could be like 42 or something like that. But see, your pH is normal, so therefore it's compensated. So it's fully compensated because the pH is returned back to baseline. So you'll see values like that in like your COPD patients. Always, 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 their bicarb is like high, sky high. pH is normal, and your CO2 is high. So that's a classic COPD patient. Also, like a respiratory alkalosis would be like pH of 7.48, 7.75 even. And on this one, the patient, instead of being hypoventilation, which is retaining the CO2, alkalosis is going to be like the patient's hyperventilating. So say their CO2 is like 28, 26, 22. And my bicarb, because it's noticing, hey, my pH is really, really high. I need to bring, I need to, come back down so I can bring my husband off his high horse. So let me try to come down here and bring him back to earth a little bit. You can think of it that way, as, like I said, as other analogies. But so the bicarb is going to come down, say to maybe like 18. It's going to come down because it knows that that pH is going to follow him down. So then it'll try to partially compensate for that respiratory alkalosis. So again, when it reaches that pH reaches baseline, and say that bicarb is like at 18, and your pH is like at 7.3637, which is within normal, that's what you call a fully compensated respiratory alkalosis. Now, where on the other hand you have your metabolic acidosis and your metabolic acidosis and metabolic alkalosis, your pH will be something like 7.0. CO2 is trying to work. Is the CO2, I look at it as when it's indirectly proportional. It's like the CO2 is being like the counselor. He's trying to, okay, get in there and just help this couple out, get them back elevated. So the CO2 is going to go down because they work indirectly proportional. So CO2 is going to go down to bring that pH back up. And so the bicarb is like, what did I say, like 18 or 16, and so that's the metabolic acidosis. So when one's down, the other one's down. So when that pH is lower than 7.35, that's an acidosis. On the other hand, your metabolic alkalosis pH is like 7.5, 7.6. Your bicarb is like 50. But on this hand, the CO2 is going to be increased because it wants to bring that pH back down. So you can probably see crazy, CO2 is like 60, 65, just because it's trying to compensate, trying to bring it back to normal. So that's your respiratory acidosis, alkalosis, metabolic acidosis, and metabolic alkalosis. Now, what to do with some of these blood gases? It's important to know not just what these numbers are representing, but what do you do? So, say, hey, patient comes in, motor vehicle accident, 6.9 pH, CO2 is like 100, bicarb is like let's say the bicarb is, what is it, 50, maybe 45, 50, because it's trying to bring that pH back up, because it's like 6.9 is like death. So what do you do with that? It's like, okay, more times than not, you're going to go ahead and the doctor's going to be like, okay, we need to go ahead and intubate. There's no putting this patient on BiPAP, no nothing, especially coming in a motor vehicle accident, trauma blood, and everything like that. They're going to quickly, after they get the blood gas, see the results and be like, okay, we need to tube this patient. So, that's what you do. You tube the patient, you put them on the ventilator. When you put them on the ventilator, you're going to pick appropriate settings for the patient. Based off their ideal body weight, and from there, looking at your blood gas, going to be like, okay, I need to get the CO2 down. The CO2 is 100. Okay, I need to increase my rate because the problem is the patient is hyperventilating. He's not breathing. He's not getting rid of that CO2. So we need to increase that rate so we can blow off that CO2 as fast as we can. If we're not increasing the rate, we're increasing the pressure. So increasing the pressure will give you more tidal volume, and the more tidal volume will blow off. Or if you're not on a pressure control, you're doing a volume control, just increase the volume, So you can either increase your pressure or your volume, or you can increase your respiratory rate. Those are the things that can help blow it off. And typically we'll get a blood gas 30 minutes to an hour after we intubate. So, and so we can see if we're heading in the right direction and what else we need to do. Now, if you have a case where somebody comes in and, they're having a respiratory acidosis, pH is like 7.2, CO2 is like maybe 60, 65, 70, and the body's trying to compensate by carb is like maybe like 35. So, look based upon the patient's like, okay, and they're not a COPD patient, they're not compensated, and the way you can tell that they're not compensated is their pH is not within normal range. So it's like, okay, what's the next step? Do I put them on bicarb? Do we intubate? What, this is where you get with your doctors or your nurse practitioner, see what you want to do. But in that case, I would suggest BiPAP because the patient, sometimes we can bring our patients back on the BiPAP, get them on top of the BiPAP, put them on good pressures, good rate, and blow that CO2 right on off. But again, always evaluate your patient because you can have a pretty decent blood gas or not too bad of a blood gas, but your patient looks like he about to die. So always look at that patient. Be like, dog, okay, I know these numbers, but you always look at that patient. Let's see, anything else? Yeah, blood gas is just, I just wanted to come on because, blood gas, I love blood gas interpretations. It's so fun. And especially if you put try to make up an analogy or something to go with it. But it's, as a student, it can be kind of like confusing. It's like, okay, which one does this say? Because even sometimes it's like, okay, all right. Okay, that's proportional. That's not proportional. This is like that. So sometimes it can be like, okay, kind of confusing sometimes, or you can get kind of turned around sometimes, but it's not so bad. But it's always important, and I've seen RTs that don't know how to really interpret their blood gas, and I'm like, oh my god, I mean, it's not downplaying them or anything like that. So it's just that it's very important that you know what to do, because you're a respiratory therapist. You went to school for respiratory therapist. You're not a knob turner. And a lot of places, hopefully find a place that, they approach RT, they want your opinion, they want your advice, they want you to go ahead and be like, okay, this blood gas looks like this. They're going to look at you like, why didn't you fix this? And a lot of times you get a resident and they're new and they don't know about how to interpret yet, and you have to kind of help them out. And it's not downplaying anybody. It's just, always my whole thing is, you always motivate. So if you find somebody, a therapist that does not know, exactly how, to interpret, just nicely just show them how to do it. Show them a chart. Never ever downplay somebody. It's some things that you don't know, that somebody else know, and you won't want them to make you feel bad about yourself because you don't know something. And yes, we learned that in school, that's like the basics, but still some people, you have older therapists that they might have been on the job and had to learn and stuff like that, so they depending on what facilities, because some of these facilities out here, they want you just to turn knobs. They don't want your opinion. They don't want your advice. The doctors want to just do what they want to do. And when you're constantly working in that for like 30 years or so, you're going to, more than likely, you'll forget how to interpret because they wouldn't let you be an RT. So never ever, downplay somebody because they don't know how to interpret. just always, always just be nice, courteous, and, if they're willing to learn, just sit down and teach them, you know. Just imagine if it were you, you would want somebody to nicely sit down and teach you. But anyway, I hope this video helped someone. If you have any questions, if you're a student and you want to know a little bit more, I'll be glad to help you. It's so much fun. I enjoy it. I work in peds now, but I so miss my ABGs. But here we just do cap gases, and a lot of times, especially like in a PICU, the nurses, they'll get the gases. So, but I actually miss. I used to work in the ER all the time, and so we would get the brachials, the fem sticks. Oh man, I kind of miss my blood gases sometimes, and but it's all good. I love the field that I'm in. It's a good choice. But anyway, if you have any questions, comments, want to chat, just hit me up. Hope you have a good night. Night. Bye, guys.